Coming to you from the American College of Emergency Physicians annual meeting in Boston, Massachusetts. This is ReachMD. I'm Dr. Matt Birnholz. I'm joined by Dean Wilkerson. He's the Executive Director for ACEP. Dean, it's a pleasure to have you with us today.
Thank you, Matt.
So, obviously, having you with us is a rare privilege. It gives us a chance to think broadly about a lot of the initiatives, the main priorities for ACEP. And one of them, as I understand it, is a true emphasis on quality, which I hear across several associations, but the steps that I've heard ACEP taking to really delve into this seem more richly deserved of praise, if you will. Tell me a little bit about some of the steps that ACEP is taking towards ensuring and emphasizing quality.
Well, thank you. Yes, that's our the crux of our mission statement, is to provide the highest quality of emergency care. That's what our goal is. And as you say, the government, private payers, the certifying boards, everybody is emphasizing, improving quality, delivering more value to our healthcare system. So one of the things ACEP has done just in the last 6 months is to be approved for a qualified clinical data registry, where our members will begin reporting on true quality measures, not something silly like give the person an aspirin when they come in. There's some things that are process measures, but we're really looking at improving the treatment of sepsis and chest pain and collecting those quality measures. So that's something we're very excited about. We've created the Clinical Emergency Data Registry, CEDAR, and so we're looking forward to growing that. We think we'll have about 4,000 physicians enrolled by the end of this year.
So this is just rolled out, just recently created?
Yes. We were approved in April by the Centers for Medicare and Medicaid Services, and so we've been working hard about the last 3 or 4 months, and several decent-sized emergency department groups have come on board. We're working and piloting with some of the largest ones, and we hope to get them on board. So CEDAR is a major quality initiative. We were also just approved. We were one of, I think, 39 or 36 organizations approved by the Centers for Medicare and Medicaid Innovation, CMMI, to get a, I don't know what it's called, TCPI, whatever that acronym, Translational Clinical Performance Improvement, I believe is what it is. Anyway, they gave us a CMMI grant, and we're going to, it could total $3 million over 4 years. We're going to engage about 2,000 emergency departments. And the objectives of our grant are to promote and implement our Choosing Wisely recommendations, which most of your listeners, I believe, if they're in the medical field, they're supposedly better for patients, these things that we are on our Choosing Wisely list, plus they save money to the healthcare system. So that's one thing. The other is the early diagnosis and treatment of sepsis, which is one of the main killers, people that come to the hospital. And then the third is the management of chest pain. So our CMMI grant, our CEDAR registry, we're also doing a lot of work with the American Board of Emergency Medicine, our certifying board, developing modules for them, a patient safety module as part of their maintenance of certification, and some performance improvement modules. So a lot of good things going on.
Yeah, clearly. Let me broaden the scope a little bit. Obviously, the repeal of the SGR, some things changed in that respect in terms of quality reporting. Did ACEP play a role in that, or is it playing a role in responding to that with the way that your initiative is moving forward?
I feel like all of the above. I mean, in fairness, the American Medical Association, the AMA, led the charge, led the movement, and we've been working on it for the whole time I've been here. I've been 11 years with ACEP. We've been trying to repeal the SGR, but ACEP, along with others in the medical community and the AMA, were successful. But I kid people, I feel sometimes like we may be the barking dog who caught the car. We got the SGR repealed, but now with the Medicare Access and Chip Reauthorization Act, MACRA, as you point out, MACRA is heavily driven by quality improvement. There's kind of two prongs of how doctors might be paid. One is referred to as MIPS, Merit-Based Incentive Payment System, which is kind of a continuation of the system the government's been using, previously. And I don't want to get into too many acronyms. PQRS, Physician Quality Reporting System. MIPS is kind of that on steroids. And then the other prong is alternative payment models. So ACEP has task forces that are looking at how could we fit into some alternative payment models, how could we use our registry to show the government and payers that, hey, look, we're implementing Choosing Wisely, we're saving money in all these areas, and so pay us in a different way based on, the value we're delivering. So we'll see.
We will see.
So it's a little nerve-wracking to think about, Brave New World.
Yeah, well put. It is sort of a brave new world.
Fee-for-service is going away. It's not going away tomorrow, but it will be going away, I believe, over the next 3 to 5 years. And so we've got to figure out how to adapt.
Right, towards more outcomes-based models.
That's right. That's right.
Why don't we shift gears a little bit and talk about another initiative that's going on with ACEP, and it's been floating around the term of the medical neighborhood. Tell me a little bit about what that means to you from your chair as executive director.
Well, as I'm sure your listeners know, the patient-centered medical home is a pretty well-established concept for primary care. But as we all know, there's not enough primary care doctors. There are many physicians in the country that don't take Medicaid. They don't take new Medicare patients, even as 10,000 people a day are getting eligible for Medicare. So our visits, it's anticipated that when the new CDC numbers come out, it will be 150 million that are visiting the emergency department. And that's even as we have the advent of more urgent care centers, retail clinics, telemedicine, community paramedicine. The public are voting with their feet, to come to emergency departments. So, the medical neighborhood concept, we want to be more about care coordination and helping patients when they come to the ED find an appropriate situs of care, follow up. And we have some things in the works. It's not fully developed yet, but we're hoping to work with the developers of the National Emergency Visit Reporting System, NEVRS, NEVRS. We're in negotiations now, but we believe it's going to be a really good care coordination system that'll help. So that 68% of all hospital admissions come through the emergency department. So we're the front door to the hospital, and we believe we're the porch of the medical neighborhood. We can somehow, see the patients, and particularly acute care that's after hours, weekends. Most physicians' offices aren't open. So we have to figure out as a society, and I believe part of the solution is if we could, and I'm sure your hospital listeners want to shoot me, but somehow we have to figure out that there's not such a terrible facility charge for those visits. If you come to me and you think you may have broken your ankle, sprained severely, and you're in a lot of pain, you shouldn't get an $800 facility fee on top of that. My fee may be $120 to see it as a doctor. And so somehow we have to figure out how the ED can be part of the solution and not be a failure of the system, so to speak.
Do you think that's a particularly long-term kind of goal, or is that something that might come happenstance with a number of the policy changes and practice shifts that we were just talking about earlier as far as quality reporting and such?
It's likely a longer-term goal, realistically, but it is the delivery model for the Kaiser system in California. If I have an ailment at 6 in the evening, I go to the hospital, and they have a mechanism or a fast track, or I show them my card, and I get my treatment at the hospital. Kaiser does that. I think the Scott and White system in Texas. So a lot of integrated healthcare systems are figuring out how to do this. They spread their costs, and they don't just lard a bunch onto the emergency department. And so we're going to have to figure out how, more broadly, in hospitals that contract with their emergency department group and they're not employees, how we can do that. And again, we've got some ideas. We're trying to do that, because that'll really be the golden ring for our specialty. If we can show that we are part of the access to patient care, we're creating access. We're not just driving up costs in some way.
Right. Well, if you're just tuning in, this is ReachMD. I'm Dr. Matt Birnholz, and I'm joined by Dean Wilkerson. He's the Executive Director for ACEP. Now, a sentiment that I've heard strongly repeated along the lines of this medical neighborhood is that, yes, the medical home is endorsed. Everybody thinks it's wonderful. It would be great to see. But for one reason or another, unfortunately for the system, but fortunately that it exists, emergency medicine can serve as the home for the homeless, the medical home for the homeless. And there's a sentiment of not wanting to be villainized for playing that role, which is filling a massive gap right now. Mm-hmm. How do you respond to that? A number of the people in ACEP have voiced that sentiment.
Yeah, I mean, you're exactly right, Matt. It's a catch-22, and people say, oh, the people with less urgent conditions shouldn't be going to the hospital. But if you call your primary care doctor's office, after 5, they probably say, go to the emergency department. So, again, I think we have to figure out how to have fast tracks and have a different pricing system for less urgent care. If you come to me with a gunshot wound, you're going to get the full trauma experience with all the resources, and it should be a hospital should be highly paid for that, but somehow we have to figure out where we can provide that. And I don't have the answer to that. I mean, our country is expanding Medicaid, which in almost every state is a low-paying, does not cover cost, and so the emergency department has a federal law that we have to see every patient that comes in that thinks they're having an emergency. And so I wish there was a way that policymakers would be more understanding of that. We're just doing our mission and our duty and what we're required by law to do. The uninsured, Medicaid, Medicare, and as I'm sure you know, a lot of these insurance policies bought through the state-based exchanges under the Affordable Care Act, they have high deductibles, and a lot of doctors and hospitals are not in network, and so those people, a lot of them are going to come to the emergency department. So
right, and perhaps it's maybe not perhaps, certainly from I think the perspective of ACEP, to link that situation as making emergency medicine part of the problem. Rather than trying to be part of the solution, seems like an incredible misstep. What are your thoughts on that?
Yeah, well, we're always about trying to communicate the value of what we do to the system. And you being a physician, you know that cycle time for an employee who has to take off from work and goes to his primary care doctor, and then they have to send him for an MRI or a film, or they have to get lab work, or they do this, do that. There's a lot of cost off from work. There's cost of everything else. They come to the emergency department. Sometimes you get in and out in a few hours. You have a diagnosis. You have your prescription, everything. And so I think sometimes people compare us with apples and oranges to what the alternatives are. And so we're always communicating that. We did a RAND study a few years ago that had some really compelling evidence about the value of emergency care. And we're going to keep plugging away at it. Like I said, it's not that some states try to limit visits. If you're a Medicaid patient, so we only get 3 visits a year to the emergency department. I mean, that was in Washington State. There was that battle, and we think stuff like that is dangerous. If patients think that they can't come to the emergency department if they need to, and it's really not fair to our people, of course, if they've had their 3 visits. All the rest of them are just on you. Like indentured servitude or something.
Right. And I think one person put it beautifully with the play on words when he said, listen, it's not rocket surgery. And he said, we're often cited as villains in this whole process. Our role seems to be equated with being the bad guys in the move towards medical homes and towards, but we are not. We're actually trying to hold the ship together.
Right.
So perhaps words to live by, at least in these walls.
Mm-hmm.
Why don't we shift gears one more time, because there's one other area that I know is important, an important initiative going on that has to do with balance billing. Mm-hmm. Admittedly, an area I know not too much about. What can you tell me a little bit about what's going on there from ACEP's point of view?
Okay. So in a nutshell, just for folks who are not familiar with the concept, physicians and hospitals negotiate with insurance carriers as part of their insurance network. And in the course of the negotiation, sometimes, an Aetna, Cigna, United Healthcare, Blue Cross, I'm not picking on any particular one, but they would say, okay, I want to pay you, $30 for that procedure. I want to pay you a Medicaid rate or Medicare. And you as a doctor may say, that's not fair. I'm just not going to be in your network. So if you're out of network, most insurance carriers, like we have health insurance as ACEP employees, and if you go out of network, you pay a higher copay, and you're subject to getting a balanced bill from the doctor because he's not in your insurance company's network. They just pay whatever rate your plan provides. So, there's been a lot of controversy about this, that patients get surprise bills or bills they didn't expect. Obviously, if you know you're going out of network, if you go to have some hand surgery, let's say, and you check your book from your insurer and your doctor's not in there, well, you go into it with your eyes open. Okay, I'm going to have to pay more. He's out of my network. But where it's a problem for us is that sometimes your hospital's in network, but the emergency department group or the anesthesiologist or the radiologist or the surgeon or somebody's not in network. And so that's a problem. It doesn't seem fair to the patients. And I understand that. And of course, I work for a physician group, but I believe in many cases the insurance companies are, I believe, scandalously creating narrow networks and shifting costs to the patients. And then they're trying to make the doctors look like bad guys and say, well, it's just the greedy doctors. No, the reality is, in many cases, you, insurance company, are not paying a fair market amount for those doctors. Those doctors might be in network with several other insurers, but they're not in network with you. And so you're just shifting cost to your patients or customers. So you may know this week we released a poll that, 7 out of 10 of our members say that people come that, they've only got one insurance plan with a very narrow network, and they can't find a doctor in their network, and so they come to the emergency department. And so there's skirmishes at the state level, skirmishes at the federal level, how we can try to come up with a fair system.
Who's going to wage that battle with the insurers that are engaged in this pretty transparent practice of trying to deflect the payments over to the patient? Because obviously the alternative solution of having physicians in the emergency departments not ordering services from any other departments is a little bit egregious. So where does that war get waged?
Well, we are waging it on a number of fronts. CMS, the Centers for Medicare and Medicaid Services, they have regulations pertaining to this, and we're asking them to have a different interpretation or a different way that their rules would apply to insurance companies. The National Association of Insurance Commissioners is an NAIC is an organization of all the state insurance commissioners, and they're working on a model law that would apply to these situations. And of course, we're in there with the AMA and other organizations saying, well, you need to make sure there's an adequate network. You guys need to set standards for adequate networks. And if you do that, there's going to be a lot less of this, out-of-network billing. And so, we're waging the war there. And then, of course, in legislature, state to state. As I think I mentioned to you before you started the show that we have 53 chapters. And so in every state, not every, but in a dozen of them, there's legislators are looking at this. So there's a bill that's just been introduced in Congress that, again, we think is very unfair. It's the Surprise Bills Act or something like that. Senator Lloyd Doggett, Congressman Lloyd Doggett, and it would just basically ban the right of physicians to send a bill to a patient. Well, that just hands everything to the insurance company on a platter. They can say, I'll tell you what I'm going to pay you. If you don't like it, you can lump it because you can't you can't bill the patient. You're just out of luck.
Well, we have to wrap up in about a minute or two, but before we do, any parting comments that you want to add for our audience?
Well, I really appreciate what you're doing here at ReachMD. You're really helping to, I enjoyed the one you did with my counterpart with obstetricians and gynecologists. Hopefully your listeners can learn more about our specialty, and just appreciate you raising the awareness and knowledge level of people.
Our pleasure.
So,
thanks to Dean Wilkerson, Executive Director of ACEP. We've been talking about a whole gamut of issues that are central to ACEP. And again, Ms. Wilkerson, thanks so much for your time.
Thank you. Appreciate it.
To access this, other podcasts, videos, et cetera, for ReachMD, please come to reachmd.com. We'll be seeing you there. Thanks again.